Everybody, welcome. Thank you so much for your patience. I had a very scary personal technological issue, but I'm so glad that we are back online and good to go. I hope everybody is doing well today. Let's just give it one quick minute to allow people to sign on. Looks like my screen share is just taking a minute, probably related to all the crazy technical issues I was having. Oh my goodness. Alrighty, so it looks like we have most people are on and logged on, so thank you everybody for joining today. My name is Chelsea Fix, and joining us for a conversation is Dr. Mamatha Pasnoor. So this is our June speaker series, where we will be learning about the guidelines for diagnosis and treatment of GBS and CIDP. As I said, Dr. Pasnoor is joining us today. She's a clinician at the Kansas University Medical Center and a member of our Foundation Global Medical Advisory Board. Thank you so much for joining Dr. Pasnoor. A very quick thank you to our sponsors of our speaker series and our education and our virtual education programs. And a reminder that before we start asking Dr. Pasnoor questions, that these webinars are meant to be educational and are not meant to troubleshoot or consult on individual cases. As always, please talk to your doctor about your care. If you do have a question, please type it into the Q&A box below. But again, remember that we won't be troubleshooting specific circumstances, but please feel free to utilize that Q&A box below for some general questions. So with that, I'm going to stop my screen share and let's go ahead and get started. So Dr. Pasnoor, the first thing I want to mention is that as we get into the GBS and CIDP treatment guidelines, first we're going to learn what does that actually mean. But also I wanted to get into, you did not develop the guidelines personally, but you are a physician who utilizes them in day-to-day practice. Is that fair? Is that a correct assumption?
Yes, that's right. Well,
Yeah.
thanks for that introduction also, Chelsea, and thanks for allowing me to be part of this conversations here today. And yes, the guidelines I wasn't part of this guideline, specific guidelines, but I've been part of other guidelines before. And as a clinician, I do use these guidelines. And, we can discuss more on the development of that, but, once, we can continue then.
Yeah, that's great. So, um, I want to mention where to find the guidelines on our website as well. So, if you visit gbs-cidp.org, I would share my screen, but I'm, I'm a little nervous about
I
messing up
think
my Zoom. It's a little finicky
I
right
think you were
now.
freezing up a little bit.
Um,
Sorry.
I think we're good.
Okay.
Oh gosh. I hope this is getting better as we go along. So, as you visit our website, gbs-cidp.org, under Understanding Our Conditions, there's a section in the middle there called Educational Resources, and you see Diagnosis and Treatment Guidelines for GBS and CIDP. So that's where patients can find the guidelines on our website. So Dr. Pasnoor, you mentioned being part of other guidelines processes in the past. So can you describe how are these guidelines created, how are they developed, updated, and who contributes to the process?
Exactly. Yeah. So this is an important process. As we know, like the European Foundation of American Neurological Societies and along with the Peripheral Nerve Society and developed the CIDP guidelines, and we'll go through the details of that. And the GBS guidelines were by European Academy of Neurology along with the Peripheral Nerve Society have developed the GBS guidelines. So this is basically, it's usually, initially we start off with creating a task force, which usually includes like specialists in this area, like experts in this area, like GBS or CIDP specialists all over the world. They are selected. For the CIDP 2021 guidelines, we had 17 total experts in this total task force created. So this also includes a patient representative because we do want a patient's voice heard also as part of the guidelines. And there are also methodologists like statisticians and others also included in this. And so it is a combination of all these experts coming together and going over all the database, all the published data from prior studies and literature and all that, and then coming together and putting it together and coming up with some questions and then trying to answer those questions for each of these, how to diagnose, treat, and manage the CIDP or GBS. And where there is not much data, usually it comes up, we usually come up with the consensus, which is like a voting process where you're coming up with a statement and we decide if all the experts, agree to that, then that's a consensus statement that comes up for this. So these are all, again, published as guidelines for other clinicians to guide them, basically, and help with the diagnosing and better management of CIDP and GBS, treatments in this group.
Yeah, I think it's really important to know that all of these are evidence-based, based off of the literature, and that a full literature review is done. And by literature, this is stuff, stuff. These are research that has been done in controlled environments and published in peer-reviewed medical research journals. So this isn't really preferences of physicians. Is that correct?
Yes, that's right. This is based on published data. When we talk about published data, we're talking about literature like research that has been done. This is all over the world, not just in US. We are looking at the primary literature is like where the original research articles and meta-analysis. I mean, we also have like other studies like meta-analysis. All of this in these are all in well done studies. Again, I have to say, because again, some are rushed studies that we see sometimes, but these are all well done randomized control trials, majority of them, and we take and into consideration all of these for to come up with the guidelines. And they are, like you mentioned, provide evidence base for treating conditions and clinician decisions. And these are all from reputable medical journals. And, so those are all taken into consideration to come up with these guidelines. So it's not like a rushed, a thing that we do. It does take some time to go over all of these questions, coming up with the questions, and then looking up multiple databases like, we talk about PubMed, we talk about Cochrane database, these are some of the databases I'm just mentioning, but there are a lot of journals like, reputable journals that we go through for each of the questions that we have. For example, like, for CIDP treatment, what should be the initial treatment? And we look at all the data that has been published, what are the trials that have been done in this area, and then we decide on, to come up with the guidelines based on that.
Right. So today we're really focusing on the GBS and CIDP guidelines. And the elephant in the room is, what about MMN?
That is an interesting, an important question, and actually, that's something which we are looking at, and something that will be definitely something this group will be looking at coming up with in future. I'm thinking in the next 1 or 2 years, we probably have some guidelines published, coming up with some guidelines for MMN, hoping that, again, these are all rare disorders we all have to realize, and it's not common that we see these conditions. However, as the awareness increases, I think there's more advocacy from the patients, and again, there's more awareness, and we are recognizing these conditions more often, and that's why I think we are able to come up with these guidelines. And I think it's more important for us to come up with these guidelines for other treating physicians also.
Right, right. So they are available for any physician to use, and we'll talk a little bit more about that later. Let's dive into the scope of the guidelines. So again, we're on GBS and CIDP guidelines. So talking about them broadly, how do they account for variants of GBS or variants of CIDP within the guidelines, and how those variants might be treated differently?
Yeah, that's a good question. So the guidelines clearly state, for example, GBS, we have the GBS and the GBS variants. For CIDP, they have detailed diagnostic criteria for for the variants, and they have specific criteria for common variants like, again, in 2021, we have the distal variant, they have discussed about the sensory variant, the motor variant of CIDP, and the focal unifocal, multifocal variant. So these are all specific type of variants that have been discussed. The diagnostic criteria has been discussed specifically in this. And then the electrodiagnostic tests also necessary to make these diagnoses. And then there is like supporting criteria is important. And based on the guidelines also mention the differential diagnosis. When you see this variant, it's important for us to make sure that it's not you're not missing other differential. They can mimic other conditions. So sometimes these supportive tests might help us to differentiate these from other differential diagnosis. So they have mentioned that they have given us like what if it is motor CIDP, what can that mimic like? And so these are all very important. So the guidelines acknowledge that there is like variability in GBS and CIDP, and so they have come up with these criteria, specific criteria how to diagnose the variants. And I think and guidance on treatment also, like some variants are treated differently. Like for example, motor CIDP, we treat them, that the initial treatment for that, unlike other CIDP, is IVIG and not, I mean, corticosteroids are usually the first line for the others, but in this case we are. So they have even mentioned that like treatment specific for some of the variants, I would say.
Okay. Going back a little bit to the scope, so we know that the guidelines really cover how to diagnose these conditions, what to look for as diagnostic indicators. Since neither GBS nor CIDP have a biomarker, we're kind of relying on those indicators, right? So that's all laid out in the literature, and then some of the treatment is laid out in the guidelines. Are there things that are not in the guidelines? So we got a question about pain and pain management and some of that long-term living well with GBS or living well with CIDP, things that we do, physical therapy, pain management, all of that good stuff. Are those in the guidelines or should they be?
Yeah. So I have to say, like, there's no specific information on the guidelines for pain, but basically the recommendation is that you follow the same as any other neuropathic pain for the GBS or CIDP pain. And as far as living well, and I have to say some of this, other factors like diet and physiotherapy, all this is not specifically mentioned, but there are some guidance. They did mention that they have to be considered but however, there's no specific trials on this to make a guidance or, but in general, the consensus is like we have to look into like the supportive care even after the GBS or CIDP. After the acute treatment, you need to look at the pain, the psychosocial aspects, and the autonomic in GBS. These are all some of the things that have to be considered and treated and managed, like the respiratory problems afterwards, like long-term rehab. If they have weakness, like having developing a rehab plan, physical therapy, occupational therapy for patients. So these are all not the guidance. There's no specific guidelines, but that's because we need more trials in this area. But they did mention that this is important to consider for long-term recovery in our guidelines.
Yeah, so it sounds like that they might reference other guidelines, like for pain management. So really, they're going to default to the experts on pain management to manage that pain, similar to GBS or CIDP, and follow the typical guidelines for that. And then it sounds like we really need more research, peer-reviewed, clinical trial type, high standard quality research for something like that to be included in future guidelines like this, in terms of living well in that supportive care.
That's right.
All right, let's get into what the guidelines actually say. So this might be a quiz for you. I hope you brought your notes or flashcards. Let's start with GBS. So what are the current first line treatments for GBS, and what is the evidence for reasoning for these recommendations? And again, thinking about how do the guidelines say to treat Guillain-Barré syndrome?
Yeah, so the first line treatment is basically for GBS is mainly as we all know, like plasma exchange and IVIG. These are the first line treatments. And again, based on, when we see the patient, like, is it like between 2 to 4 weeks or for before 2 weeks, IVIG versus plasma exchange. And again, depends on individual patient, also like, the comorbidities that the patient has, or is it rapidly progressive? You're looking at the availability. Again, IVIG may not be available in some countries, or exchange may be easier in some. And then the IV access, some people it may be difficult for the IV access. But as far as we know, like, between 2 to 4, up to 4 weeks, if they are walking unable to walk unaided, like you use plasma exchange within 2 weeks, it's IVIG that we use. And again, if someone has kidney problems or clots in the past, you cannot use IVIG. Plasma exchange would be the treatment of choice. And so but these two are our first line treatment options for GBS.
Right. And again, these recommendations come from literature and from evidence. We got a question about kind of as that evidence is gathered and put into guidelines, how do we ensure that the medication, the methodologies, medications and the methodologies for treatment, things like that, that they are up to the highest standard, that there's no kind of unscrupulous or anything that might not be held to a good standard of research? How do we ensure that doesn't sneak its way into guidelines?
So, the best thing would be having a randomized control trial, I would say. Something, when I say randomized control trial, for people to understand is, you measure a treatment against a sugar pill or sugar infusion, something like a plain saline infusion, I would say. So the best way to assess that would be something like that. So when you look at that and you see that the benefit of the treatment was way better than the not giving any, like giving a saline infusion or placebo, what we call as placebo, that would be the best, trial to say that is the greatest trial. But unfortunately, like I have to say in GBS, that is not possible because we already had plasma exchange established for a long time. So IVIG was not exactly looked at, placebo versus plasma exchange. However, by the time IVIG came into the armamentarium of like treatments, the plasma exchange was already being used. And so the trials were mainly looking at the efficacy of both compared to plasma exchange. And they have seen equal efficacy of both the IVIG and plasma exchange. And that's how we decided, that both these are effective treatments. And there are other medications that are being looked at and other mechanisms that are being looked at this point. I mean, at the time of these guidelines, we didn't have any other medication that has been approved or has been, studied extensively, I would say. So at this point, we have only these guidelines, and these are the two main treatment options for GBS. So again, I would say this would be the highest. If they're using it right, and if you're using it in the right doses and according to the guidelines, it would be the best treatment.
Yeah, and peer-reviewed medical journals, it's not easy to get something published. There has to be a high rigorous review process by other people who know these kinds of methodologies and know the conditions and know the diseases to make sure that the methods are up to standard before they even get published. And then the guidelines committee is probably being even more more going through those with a fine-tooth comb, being more picky about what gets included as that evidence too. So I think there's kind of a two-step approach to making sure that all of that research being done is up to the highest standard, and it's not just it's not just a study that was put out there and then makes its way into guidelines. It's very thoughtful and um, you know, difficult process to have that level of evidence. All right, so back to the GBS guidelines quiz that we're doing here. So we talked about the first line treatment. So if a patient doesn't respond to first line treatment for GBS, still on Guillain-Barré syndrome, what are the typical next steps according to the guidelines?
For the GBS, basically, I mean, that's the treatment that we use. So, if someone does not have improvement in the symptoms, then the question is, I mean, relooking at the diagnosis, that's first thing, making sure that this is not an acute onset CIDP or progressing CIDP, or even trying to see if this is other some other disease condition. So we need to make sure that it's the right diagnosis first thing, and and other approaches would be like making sure that the respiratory is proper, and making sure they're getting physical therapy, and trying to get them to move, and so these are some of the things that we need to do if someone I mean, did not respond to the initial treatments. And, again, so there are the guidelines did mention that, supportive diagnostic testing like, CSF analysis, or doing the nerve conduction studies. These are all like, other tests that you would do to make sure that we are right at the diagnosis, and monitor them closely.
Thank you so much. So before we move to CIDP, we do have an audience question talking about risk when it comes to treatment. So how do the guidelines handle mitigating risk? And especially do the guidelines kind of call out the risk or things to be aware of in patients, such as patients who might be older, over 70 or so? And over 70 is just what the person typed in. That wasn't my cutoff for the record.
Yeah, definitely. I think the guidelines did mention that the risk of prolonged mechanical ventilation, and the risk of having more severe disease might be more with age. And so there are some indications of, like, they did look at various age groups. I mean, although the guidelines are for any age group, but even pediatric patients were included. But again, some of this are they did mention, like, with the older age group, that you can have more risk of ventilation issues and other issues. Yeah.
Hmm. But in terms of treatment, nothing's mentioned.
Treatment is specifically this, I mean, because we have these two, which again have risks and benefits, you have to look, it has to be individualized to each patient, so not specifically for age group, but it's basically based on the individual patient. Again, the comorbidities associated with the patients, all those have to be taken into consideration when you're assessing for that.
That's actually a very good point, probably for both the GBS and the CIDP treatment and diagnosis guidelines. Of there are these guidelines that are meant to be this umbrella, but really there is this element of personalized medicine and a conversation that should be had about the individual person. And we'll get to that a little more, but that's a good call out to think about right now. And I'm glad it sounds like you said that the guidelines mention that there should be that individual consideration for each patient.
That's right.
Good. Okay, great. Let's talk about CIDP now. So kind of that same question. For CIDP, what are the recommended first line therapies? And how are those selected for the guidelines? We've kind of gone over that, but just as a refresher.
Yeah, so that's true. I mean, not much of a difference except for the corticosteroids come into play in this. In addition to having IVIG plasma exchange, we also have corticosteroids as the first line treatments for the CIDP patients. Again, like we mentioned earlier, it depends on individualized treatment for patients. And although corticosteroids and IVIG are considered more often than plasma exchange, again, it's mainly because of the access, IV access, and the side effects of the treatments. That might be one of the reasons. But if you have a rapidly progressive severe disease, the recommendations are IVIG or plasma exchange might be better as a first line. But basically, all three of them can be used as first line treatments. But like I said, for rapid onset, IVIG and plasma exchange might be more useful. So again, the consideration for individual consideration, like I mentioned, if someone has difficulty with IV access, then again, it might be corticosteroids might be useful. and then plasma exchange might be difficult in those patients, So these are some of the things to keep in mind. And if someone has clots, again, we talked about that, or renal dysfunction, then plasma exchange might be better over IVIG in those patients.
Yeah, so it does sound pretty similar that the GBS and CIDP treatments are originally from the same arsenal, but the CIDP guidelines might be more urgently updated as we know some more things are coming to the market. We do have a new FDA approved therapy since those guidelines are created. But then the CIDP guidelines move on to maintenance, where we know GBS typically is that one-time treatment, and then the long-term recovery and supportive care. CIDP treatment has that kind of maintenance period. Can you talk a little bit about what the guidelines say for that maintenance period?
Yeah, for the maintenance, basically, they do suggest either any of these can be tapered down and either IVIG, but in addition, they also mention the SCIG for maintenance, which is subcutaneous, giving under the skin, in the fat, basically. That would be the subcutaneous IG can also be used in addition to like tapering doses of prednisone or steroids, or it can be IVIG maintenance every 3 weeks is what the recommendations are. Or but there is quite variability in that too, and it has to be catered again according to the patient's needs. And some people may need more frequently, some people may need again different doses. So we need to cater it to each individual patient. And I'm glad that you brought up the new treatment. Actually, forgot to mention that, but that's not the first line right now still, but it's still an option for patients. And it's because this guideline was before it was approved. I mean, we don't have, and the plan is that these guidelines would be updated every 5 years, and hoping that in 5 years, like from 2021, when new guidelines come up in CIDP, we might see more medications added to this list, at that time.
Yeah, 5 years. A lot can happen in 5 years or not a lot. So I guess
Oh,
we'll
I have to
stay
say, I
tuned.
mean, the studies do take a long time. So, if you're doing a prospective trial, the minimum would be 5 years, I would say, to get the results published and everything, So it does take a long time for the results to come in newer trials. So there is a lot of interest and a lot of new studies ongoing to treat the CIDP presently. I wouldn't say there's a huge number of trials going on in GBS, but CIDP definitely there's a lot of new trials ongoing, hoping that there'll be some new mechanisms that we'll be targeting in future.
Yeah. And a plug for our website here. If you visit our website, there's a button at the top that says research. And if you follow that to participate in research, we do list clinical trials that are happening for GBS and for CIDP and for MMN because we know we need the MMN guidelines very soon.
That's
So I want to go back to the CIDP maintenance. And you mentioned that the guidelines do have this kind of maintenance period and the dosages that are in there, but that they do recommend tapering off of that medication. So let's talk about that because I think that can be a little scary for patients to hear. First of all, to be on CIDP and then told, okay, we're going to take you off your medication. So, can you talk a little bit about why that is in there and then the process of typically coming off of that medication and how, the monitoring? So, this is going to be chunked up. I think we're going to talk about this for a while.
Yeah, this probably is going to be a little bit of a discussion there because again, there is also quite a lot of variability, I have to say. There's no specific, I mean, the guidelines do suggest tapering off. That's the number one that we all have to realize that people can go into remission with the CIDP. So it's important to realize that, you may not need it forever. That's the first thing which is scary for many people because you're used to this medication and you're thinking that, am I going to go back to where I was before all this treatments were started? So that scare is always there for patients and for people but you have to realize also everything comes with side effects. And there is benefits, but there is also side effects with medications. There's long-term side effects with steroids, as we know, like there can be bone density loss, there can be high blood sugar, high blood pressure, and you can have swelling in the legs. And so there are a lot of side effects with that. And then similarly, like for IVIG or intravenous immunoglobulin, you can have clots, you can have kidney failure, you can have really like other blood abnormalities. So there are a lot of side effects. Plasma exchange, again, the IV access is a big thing, and many places do not do the peripheral lines they need central lines to do the IV plasma exchange. And so having a central line for so long, there's risk of infections. And, so there is a lot of side effects with any medication therapy. So, but if you need it, you need it. But the thing is, I mean, we need to see whether, if you are stable, if your symptoms are stable clinically, as well as, when you do I mean, we monitor patients closely with the INCAT scores, IRODS. These are some of the outcome measures that I used in the clinics as well as in research studies. We are basically asking whether, your functionality, like at home, like buttoning up your shirt, or zipping up your pants, or like, so are these a problem? Like we measure that every time you come into the clinic. And the disability score, there are different various other measures, like even the neurological examination that we do in the clinic, the clinical examination, your strength testing, and the grip strength. So these all are indicators that we follow if we are planning on tapering. So we have to have a plan in mind. So as a patient, you and as a physician, treating physician, you both have to discuss this first, and how a monitoring plan, like how if we are planning to taper it off, what should we look for? Sometimes people just feel like, they're getting worse after because they are scared of going off of a medication. And so these objective measures help us to decide, are you really getting worse or not? But if you feel like you're getting worse, you should definitely contact your physician and let them know so that they can actually physically examine you in the clinic. So that's very important to discuss and have a discussion with your physician. So the guidelines basically recommend that, you do a bolus. That's what we talk about. Bolus is like doing IVIG or plasma exchange over a few days. Like, for IVIG, it is over 5 days. For plasma exchange, again, it's like over 2 weeks. You do this initial treatment, and then for IVIG, it's every 3 weeks is what we do. But in some patients, it can be like, sometimes in CIDP, people may need like, a few more frequent, like maybe every 2 weeks. Some of the year are every 2 weeks. So there's no specific way that you would taper, but there is, we look at it individually. But what the recommendations are, either you decrease the dose, and it can be by 25% every few months, or you can just do space it out. Like instead of 2 weeks, go to 3 weeks or 4 weeks, or based on where you are, we try to space it out. So when do you start spacing it out? The recommendations, I mean, or the guidelines are that you do it after a few months of initial treatment. So about 4 to 5 months of initial treatment, and then you start tapering that down. And that's usually most of our plans are to like start tapering it, or either spacing it out or decreasing the dose, and monitoring closely and making sure that you're not worsening. If any of your symptoms are worse, then we can just go back onto the previous dose. In that way, that also gives us a little bit of room rather than just stopping it suddenly. I know sometimes we try to do that if you're in some patients, but the guidelines are like the try to taper it down might be the best thing, so that we can just go back onto the dose. And similarly, like for steroids, you can start tapering it down gradually over a few months. So that's what I would, and that's I think most of us practice similar to that.
Yeah, and it sounds like there really needs to be a lot of trust and open communication from both sides here, from the patient and how they're feeling. Even if a patient is feeling anxious about changing that, I think that that's a good conversation to have, because then maybe the tapering strategy could be adapted a little bit because we want everyone to be comfortable with the plan. But also, I think it would be helpful for the doctors as well to talk about, this is why it's important to taper, the host of side effects you mentioned, the long-term risk on the body. These medications are no joke, like you were saying. There's a lot of serious potential side effects for them. So, have you any suggestions on how patients can advocate for themselves in this situation, particularly thinking about tapering and the anxiety that might come with it?
Yeah, I think it's always important first is educating yourself, about GBS, or CIDP, the process of CIDP, and what I think that's very important first. And like we discussed earlier, is having an open discussion with your physician, and expressing all your concerns so that they can address that and they can discuss, and having a plan of what if the symptoms get worse? How can you get hold of the physicians? I know it's always, I have to say, I mean, even I might be, in that same situation, but sometimes it's hard to get a hold of physicians. But I think it's always good to have a plan and, have a number that you can call if you have worsening symptoms. Usually our nurses are pretty good about like, contacting or calling back, if you're having symptoms, and discussing, and the physicians may ask you to come into the clinic, or to examine, or they can call you and discuss with you and see what do some of these outcome measures. So it's important for you to educate yourself, and communication. These are all very important, I think, for and having a good support system, and like getting your family, maybe it might help, some things that you forget to ask, maybe your family members can discuss with your physician when you come in. So these are all important things to advocate for yourself, and discuss mainly.
Yeah, and I think being as specific as possible, like you were saying, there are these tools and measures that exist to measure disability, but they go kind of beyond saying, I feel really bad. Some of the specific things that you've noticed you can't do as well anymore, or like coffee mugs getting heavier. Those things might help you, Dr. Pasnoor, point to, okay, we need to rethink this medication plan or rethink kind of what's going on here.
Right.
We had a question from the audience about prognosis. So specifically, if neither IVIG nor plasma exchange are available, does the prognosis change for patients? So I'm not sure if that's GBS or CIDP, but maybe we could answer it for both.
Yeah, for the GBS, again, the prognosis depends on what your, in GBS, let's talk about GBS first. So the prognosis usually depends on what your initial symptoms are, how severe were their symptoms. There are scales that can measure what your outcome is going to be like in a few weeks or months. We call it as modified EGOS scale, and then there is a measure. There is another scale that we look at that tells us whether you're going to be like in having a respiratory problem, like So these are some of the scales that are done as part of your when you are admitted to the hospital to see what your prognosis is going to be. But I think it's again, it depends on, like I said, depends on what your symptoms are, what if you have a variant, or depends on that. If you don't have treatments, obviously the prognosis will depend on how severe your symptoms are. I mean, I think in this day and world, I'm sure, like wherever you're in, whichever part of in any country, I'm thinking there's some form of treatment, either plasma exchange or IVIG. One of these two should be available in most cases. And there are few patients. I mean, saying that, I have to say there are few patients who might spontaneously improve with mild symptoms, even without treatments. Again, there are some variants when we talk about, again, Miller-Fisher variant. They've seen like, maybe people may improve without treatments also. So it depends on the severity of the initial treatments. As far as CIDP, again, that the prognosis, if you're not treated, there might be a progressive worsening, in that case. So again, corticosteroids are easily accessible in any part of the world. So at least corticosteroids, I think, are good form of treatment unless there are other comorbidities. And these are all, important that they are treated early, especially in CIDP. The early the treatments are started, the better the prognosis is in the patients.
And I think you had mentioned the guidelines do account for, if this isn't available, this is the next best thing and things like that. But do the guidelines typically talk about prognosis at all, or do they look for markers of treatment response or anything like that?
They do look at markers of treatment response, like we talked about the outcome measures and other. They do talk about that, and even prognosis is more in the form of like prolonged ventilation or what the respiratory status is afterwards. That has been discussed in the GBS guidelines. That has been discussed that, and as far as CIDP, again, it can be individualized. Again, every patient is different. So it's hard to like have one prognostication for all patients, but early treatments definitely have shown to be more beneficial. And as you mentioned, I mean, if beyond this in CIDP, there are other treatment options. And again, those are also mentioned in the guidelines, although they are not the first line treatments. But if patients are refractory or have other comorbidities that we need to take them off of these medications, there's azathioprine, there's mycophenolate mofetil that can be used, and cyclosporin has been discussed. And beyond this, again, there are other treatment options like rituximab, and these are rare options. However, there are, I would say there are a few studies that have shown some benefits, and that's why they have been included in this. And so rituximab, like cyclophosphamide, these, again, there may be more side effects with these, and have to be, again, administered after discussing and making sure you don't have any of the conditions that would contraindicate from using these treatments.
Yeah, and a lot of those other, I guess, second or third line treatments are often off-label, meaning they're FDA approved for use in a different condition, not necessarily for CIDP, but like you said, there have been some studies done, some clinical trials up to that high standard of, good ethics and good science that have shown that there is benefit there. So that's why they get included.
That's right. You're right. I mean, these are not FDA approved, so I have to
Yeah.
mention that they've been, again, the only one we know of the FDA approved is, again, we have the Hytrolo efgartigimod, but again, that's not included in the guidelines because it's a recent one, and so it's not part of the trials.
Yeah. Yeah.
Yeah,
Other than certain IVIG brands.
that's
And speaking of IG, actually, we got a question about if there are any particular blood abnormalities from IG therapy. And I thought it would be good maybe just to go over some of those risks of IG therapy again, especially long-term IG therapy, with the caveat that we're so grateful for IG therapy because it does great things and it's the first line treatment and the guidelines for very good reason. It does help a lot of people. So we're not trying to IVIG bash, but there are risks to the
yeah.
therapy. So I'll let you take that.
Yeah, definitely. I mean, I think again, IVIG is, like you mentioned, is a great therapy for everyone, for most conditions, actually. It's not even just for, sorry about my phone there. So it's
That's
not
okay.
just for CIDP or GBS, but it's been used for many other autoimmune conditions. And so it is a really great treatment option. But sometimes people can have low RBC count, like you can have low hemoglobin and hematocrit, that so you can have some blood abnormalities from that. But the major risk that we all worry about is the clots. It does increase the hypercoagulability, that is the risk of clotting is major, like is I wouldn't say it's a common one, but however, even though it is a rare complication, it still is a important thing to remember. So if someone has a risk of clots, this is something which we need to make sure you let your physician know so that they'll consider other treatment options rather than this. The risk of clots, again, is, if you're on an anticoagulation therapy, you can still use this. But if you're not on any anticoagulation, that's like a blood thinner I'm talking about, then you cannot use it. And like we talked about, like your creatinine can go up, which is, again, seen in your blood work. That is the kidney failure. You can have that from with that. That's why, especially in diabetic patients, we have to be careful because they already have renal problems, and having, giving IVIG may increase that risk of the side effect from that. So, although it is a good medication, I think it's always important to also think of the side effects. And one of the ways that we avoid or monitor these is get routine blood work on patients with on IVIG. Again, there's no specific guideline on whether you do it every month along with IVIG or every few months, but it depends. Initially, when you start off, we do monthly blood work, making sure your renal function is okay, your blood markers are all okay, and then we space it out. If everything is normal, then we start spacing it out. And some people may also develop sometimes some elevated liver function, so that's another thing. Although it's not a common side effects, but it's mainly the renal and clotting is what we worry mostly with the IVIG treatment. And so one of the things that, since we are on this topic, I would mention is some of the side effects. Again, as we know, there is also, side effects of fever and headaches, and all of these can occur with IVIG. Some of the side effects have been seen less frequent with SCIG. When you use subcutaneous, again, that's one of the options that we have for maintenance in patients with CIDP instead of IVIG.
Yeah, for maintenance for CIDP, right?
CIDP, yeah,
Um,
sorry.
and we've been focusing on GBS and CIDP again because those are the guidelines that are updated. But did just want to mention MMN, the typical treatment, even though we don't have the guidelines or new guidelines. Can you just briefly mention the typical treatment for MMN, what the maintenance looks like, and whether or not that gets those medicines get tapered for MMN patients?
Yeah, so I mean, right now we know that it's IVIG that works for MMN based on some trials previously. And although we don't have any specific, other guidelines, like you mentioned, hoping that we'll have those guidelines pretty soon, most of the MMN patients may need it more, I mean, continuously. And, again, we don't have any guidance on like tapering off from the treatment. And usually I base it off on individual patient, when they come in and, see if they are stable for a long period and did not show any progression, then I may try. But most of the patients do need it more longer periods in MMN is what we have noticed, I would say, from clinical experience. But again, like I said, we need more guidelines in this. And usually, again, it can be every 3 weeks or 4 weeks is what we normally use. And the dosing is something similar that we use for like with CIDP in these patients in MMN also.
Yeah. Going back to the GBS and CIDP, I'm seeing a few questions kind of wondering about the update process, why the 5 years, and even though the guidelines were published 5 years ago, are they still relevant? Because we know there's been research that's happening. So can you just comment a little bit on, the relevance of them, even though it's been about 5 years since, or yeah, about 5 years since they were developed and updated?
Yeah. So, like I mentioned earlier, these are still relevant because we know, I know there is other, options that may come up in between. And again, these are guidelines. Again, it doesn't mean that these are that we cannot use other treatments as they come up. The clinicians are aware of, usually they do update themselves with the latest, with the latest trials. I think it's okay to use other treatments as they come out, but as we know that these guidelines do take time to, again, to organize and to come up with the, go through the extensive literature we have, and like we mentioned, like published data, and most of the trials do take a lot of time to come in. So if you were to do it every year, we may not have much of an additional data, I would say, like that would change our treatment. So that was seemed like an appropriate time duration between the guidelines, again, for again the whole process, as well as for trials to take place and come up with the results of the trials. So usually it does take time for them to come out, to be published in, and even publication takes some time. I would say a few months to a year.
Yeah.
Once we come up with the consensus or the guidelines, it usually does take some time to be published. Because again, like we mentioned, like it has to go through peer review by many experts, by other experts in this field.
Yeah, yeah. So, faster isn't always better here. And I think there's a lot of benefits to us taking time and actually looking at that literature and looking at who's doing it, and having that human expert review on it to make sure that, this is within standards, that the diagnoses all make sense and everything like that. So, faster is not always better.
That's right.
Speaking of the guidelines, I think that these are such great tools for physicians, especially ones who don't see GBS or don't see CIDP often in their clinics. And so this is a great tool. Can you talk about if you're aware of any marketing, or how do we get more physicians to use these guidelines to be aware of it? And is there a patient voice or patient role in this?
Yeah, I think again, like we talked about, the patient advocacy is very important. And, again, I have to say the GBS CIDP Foundation International, that's a very good resource for many physicians as well as patients. I think it's a good portal to have. And for physicians, I think they do have other resources. I know, like just PubMed or like, resources like that, in addition to patient advocacy or patient sites. And there are, we have the International Foundation, as well as like there are some local groups also in some of the states. So I think it's a combination of both these would also help. But I think it's mainly the patients educating themselves and talking to their physicians, and they can point to these areas of, where the physicians can look up the latest information. And like I mentioned, like the guidelines are published in the reputable journals, and with the recent AI, I'm sure there's a lot of access for physicians as well as patients to, to find them these on the websites. And we do have links, like you mentioned, from GBS CIDP Foundation International website to other local sites or trials. And we do have many industries linking to their trials. And so I think these all are resources that may help patients to navigate. And like I said, communicating with your caregiver, with your physicians about these latest treatments. And I have to say, even the advertisements now on the television, you probably see a lot of advertisements going on with the new treatments coming up. And I think it's important to discuss discuss with your physician and ask them, is this something that is right for you? Or, they may say this is a good treatment for you, or they may say or not, that may not be a good treatment for you right now, and maybe something we can discuss in future. So, but that shared decision making is also important. Communicating, shared decision making, and all these are important for both the patients to advocate for themselves, as well as the physicians to communicate with the patients.
Yeah, the shared decision making, that's such a great term to use. And again, that trust of relationship on both sides. Dr. Pasnoor, I think that brings us to the end of our conversation. This has been so helpful and informative. I'm going to share my screen, but I am a little nervous it might crash my computer again. So I wanted to say thank you before I
Thank
did
you.
that. Thank you to everybody for tuning in. If you had additional questions that didn't get answered, please go ahead and email advocacy@gbs-cidp.org, and we'll do our best to get an answer to you. Another thank you to our sponsors. And if you like this program, there are a few things to do next. Please be sure to check out all the resources on our website. I mentioned a few of them as we were going along, gbs-cidp.org. We have so much good stuff on there. So many ways to raise awareness, whether by sharing your story, volunteering. We have our walk and roll program ongoing right now. And a reminder, of course, for our patient symposium. This is our largest in-person patient meeting in Denver, Colorado in September. And Dr. Pasnoor will be there. She'll be giving presentations live. You can ask her questions live and also potentially schedule a 15-minute conversation, one-on-one conversation with Dr. Pasnoor while you're there. I also
Um,
want to thank all of our generous donors who support the Foundation's programming, like speaker series, our webinars like this. If you want to help us continue providing these resources to support, inform, and inspire, and doing these resources for free, please consider donating today by visiting our website, or we will send a link in our follow-up email. This webinar was recorded, so everybody who tuned in today and everyone who registered but didn't make it will have access to this webinar. So thank you everybody for being here. We will see you next time for speaker series. Dr. Pasnoor, thank you, and we will see you in Denver.
Thank you. Thank you, Chelsea. And thank you, Melanie, all of you. Thank you all for being on this.
All right. Okay.